Dr. Suli, and thank you, thank you so much to Advanced Cells. This organization has invited me to give a talk about the advances in diabetes, diabetes management, and diabetes treatment. And I'm truly grateful to them. And I'm also very thankful to the doctors who have joined our session and who are listening to this this talk. Now, I think this is a very important summation of the many developments that we have seen over a period of time. I'll tell you very frankly that I find myself very lucky to be practicing diabetes in this era of medications that we have available today. Because I have seen the times of those times when we had hardly few therapeutic agents with which we could help our patients. Now, in few decades, the things have changed so much that we have so many good therapeutic agents, good therapies which we can offer to our patients, and the benefit of these has been immense, but to a certain degree, not to everyone. So today we are going to discuss these newer therapies, these newer advances which have emerged in treatment of diabetes, both type 2 diabetes and type 1 diabetes, and to a certain extent some other diabetes which are prevalent. So I would like to share my slides. So we're going to talk about advances in diabetes and metabolic care. So this is a short note about Advanced Cells. It is a stem cell research laboratory. It conducts stem cell-based research on metabolic and chronic diseases. It harnesses regenerative approach, manufactures premium quality stem cells. It is a BCL2 laboratory, ISO and GMP certified. Through stem cell quality check for viability, purity, potency, and stem cells biomarkers. The products are manufactured as per CGMP compliant protocols and are accompanied by third-party authenticated certificates. So I'd like to mention here that there are no disclosures. This is not a sponsored talk. Advances in diabetes and metabolic care. Diabetes and metabolic disorders have evolved as conditions which we are all aware as complex metabolic network involving glucose, lipid, and energy regulation. Over the past few decades, paradigm shift from glucose-centric care to holistic metabolic management, which includes weight management, cardiovascular disease management, and renal health. Advances in pharmacotherapy have been immense. The latest ones being GLP-1 agonists, SGLT2 inhibitors, dual triple agonists, which have improved not just glycemic control but also have delivered immense cardio, renal, and metabolic benefits in MASLD and plethora of conditions. The rapid innovation in technology-driven care with continuous glucose monitoring, automated insulin delivery systems, and digital health tools has transformed patient self-management to a very great extent. And the integration of precision medicine and personalized care is enabling targeted therapies based on individual risk profiles and disease progression. So, as you would all understand, my friends, that the topic is immense that we have taken up. So, we are going to focus on the most important aspects of this topic that would be practical and helpful to all of us in our day-to-day practices. So, we may not go into a lot of theory, but we are going to focus basically on the practical aspects which would be helpful in day-to-day management of our patients. The diabetes burden has risen immensely in our country. In past 3 decades, the diabetes prevalence has gone up by almost 10 times when it used to be 2% in the in the Chennai studies in 1970s and 90s. Now it is almost 20% in some metros and in some states. So we know that there's a huge burden. We are going to look into that also. So these are the results of the NDIAB study, which was published last year. The final results that there are more than 100 million, almost 101 million people, adults suffering from diabetes, with an estimated prevalence of 11.4%. And the pre-diabetes prevalence is also no less. It is 15.3%. The urban diabetes prevalence is much higher than rural. It is about 16.4%. And the rural diabetes prevalence is also not very low. It is 8.9. So now these numbers are generalized all over the country, because in certain states it is very high, in certain states it is very low. So this balances, these numbers are balanced. So the national burden and rural urban pattern, as we can see from this, is that the the diabetes and pre-diabetes prevalence, we can see from 10% to 15%, and the pre-diabetes is urban and rural. Here we can see similarly. So there are 101 million people living with diabetes, whereas 136 million living with pre-diabetes. And now, why is this number very important? Because we already have 100 million people with diabetes, and in coming next 3 years, almost 30% of those who are pre-diabetic would convert to type 2 diabetes. So that means the burden of diabetes in the coming near future is only going to increase. As I was telling you, the statewide prevalence, we are just comparing few states here. In Goa, it is 26%. In Puducherry, 26%. In Kerala, 25.5%. So almost 25%. Whereas in Uttar Pradesh, it is 4.8%, lesser than other states. So this is why the normalized diabetes prevalence is 11.4% and urban 16.4%. We all know that there are different types of diabetes, and in fact, majorly we categorize into type 1 diabetes, where there's an autoimmune destruction of beta cells, and these patients require lifelong insulin therapy. Type 2 diabetes is the most prevalent of all the diabetes. It affects almost 95% of individuals with diabetes. The predominant defect in type 2 diabetes is insulin resistance with relative insulin deficiency. That means that these patients who have type 2 diabetes, the 95% of the patients that we see, they have type 2 diabetes, they are not absolutely insulin deficient. They have insulin. In fact, they're making more insulin than the normal non-diabetic individuals. But unfortunately, that insulin is not working. They have insulin resistance at the receptor sites in their muscles, in their liver. As a result of that, their glucose, serum glucose levels are always high. This is the most common form. Type 1 diabetes is much lesser. Anywhere from 3 to 5% of all diabetics are type 1 diabetics. So we have around 3 lakh diabetic individuals in our country, as compared to 100 or 10 lakhs with type 2 diabetes. Oh, sorry, 1 crore with type 2 diabetes. So as you can see, the difference there. Gestational diabetes is also very much prevalent in our country. Almost 13% of the pregnancies in our country are affected by gestational diabetes, which is due to hormonal insulin resistance. It usually resolves postpartum, but can be a risk factor for development of type 2 diabetes in both mother and the child in future. Monogenic diabetes, these are rarer but they're still present types of diabetes. These are genetic forms of diabetes, usually MODI. Type 5 diabetes, this has been recently recognized and termed as type 5 diabetes. This is malnutrition related diabetes. It is very rare, but still it is there. So let's discuss about type 2 diabetes. Type 2 diabetes is caused by insulin resistance. It is the most common type of diabetes. The pathophysiology is quite complex. We're going to look into that, even though not in deep detail. So it is due to dysfunction of insulin production and uh, we are all very familiar with this omnibus octet, which was proposed by Ralph DiFronzo in his famous lecture. That these are the eight aspects, eight organ systems which actually lead to hyperglycemia. They all play an important role. First of all, in type 2 diabetes, there's an increased insulin secretion from pancreas, decreased incretin effect, increased lipolysis, the fat cells, increased glucose reabsorption, the kidney, decreased glucose uptake in muscles. There's a neurotransmitter dysfunction, increased hepatic glucose output, and increased glucagon secretion. This happens in pancreas and the alpha cells. So all these together contribute to the hyperglycemia that we see in a typical type 2 diabetes patient. Type 2 diabetes does not come alone, it comes bundled up with other metabolic disorders. This is why it must be addressed and it must be controlled. Diabetes is a part of cluster of metabolic disorders with obesity, hypertension, and dyslipidemia. Disorders are interconnected through shared mechanism, insulin resistance, and chronic low-grade inflammation. So, low-grade inflammation sits at the root of insulin resistance, and this is what leads to further progression of diabetes complications, the development of diabetes, insulin resistance, and further on. It causes a chain of events. So, obesity, the visceral adiposity, it plays a very central role by releasing adipokines and inflammatory cytokines that impair insulin signaling. We'll just have a look at that. So this leads to a metabolic cascade. Obesity leads to inflammation, inflammation leads to insulin resistance, and insulin resistance ultimately leads to hyperglycemia, and hyperglycemia leads to the development of type 2 diabetes. In type 2 diabetes patients, there's an inherent risk in increased cardiovascular disease, chronic kidney disease, stroke, MI, and metabolic complications like MASLD. Uh, uh, there's an increasingly recognized as part of the cardio-renal metabolic. It is increasingly recognized as a part of the cardio-renal metabolic continuum, emphasizing integrated disease progression and management, as you can see here in this picture. So, what is the correlation between diabetes and obesity? Let us look at the inherent steps. Excess adipose tissue and metabolic dysfunction, the adipocyte hypertrophy, and hyperplasia is the primary step because of excessive carb intake, excessive fat intake. It is even the excessive carbohydrate that we have. It is converted into fat and deposited in the adipocytes. So initially, the adipocytes enlarge and they become metabolically active, and they release the excessive free fatty acids because they have a limit to which they can hypertrophy. So when that is reached, the excessive free fatty acids are released, uh, and they act as inflammatory mediators. They cause the cascade of inflammation. They interfere with the normal insulin signaling pathways, and chronic low grade inflammation ensues uh, with the secretion of pro-inflammatory cytokines like TNF alpha, IL-6, MCP1, and they in turn impair insulin receptor activity in the peripheral tissues, leading to insulin resistance. The systemic insulin resistance is a key driver of type 2 diabetes. Now, one thing I would like to mention here is that mitochondrial dysfunction plays a very important role and is key driver of this chronic inflammation and insulin resistance. It is because of excess nutrient which is put up to the mitochondria, which leads to increased secretion of reactive oxygen species. And these increased ROS ultimately, uh, through the cascade, lead to inflammation, chronic inflammation, and ultimately, through different pathways, they impair the glucose stimulated insulin secretion, as well as they lead to insulin resistance, decrease in transportation of the GLUT4 receptors. So, insulin resistance development, increased level of free fatty acids and inflammatory cytokines, reduced glucose uptake in skeletal muscles, just as we discussed, from mitochondrial dysfunction, promotes hepatic glucose production, body starves higher insulin levels to maintain normal glucose homeostasis, and ultimately the pancreas fails. So here is a cartoon showing what we just discussed, that due to obesity, initially we have enlarged adipocytes because they adapt and they enlarge to store more free fatty acids. But when they cannot store more, there's a rupture of these adipocytes, and the free fatty acids are released. And the release of these free fatty acids results in chronic inflammation. They release TNF alpha, IL-6, MCP1. So this is the chronic inflammatory process. This chronic inflammatory process ultimately reduces the insulin receptors. And as we can see here, the circulating free fatty acids, they increase the inflammatory cytokines in the muscles. And in the muscles, they reduce the insulin receptor activity, leading to the muscle insulin resistance. And the same thing happens in liver. The increase in insulin resistance in the liver leads to increased hepatic glucose production. So these are the two important sites where the insulin resistance ultimately leads to uncontrolled glycemia. So pancreatic beta cells are stressed and they dysfunction. To compensate for insulin resistance, pancreatic beta cells increase insulin secretion. Over time, develops the chronic metabolic stress, glucotoxicity, and lipotoxicity. And beta cell dysfunction, reduced insulin production, triggers persistent hyperglycemia. There is also an adipokine imbalance. Obesity alters the secretion of adipokines, develops leptin resistance, and decreases adiponectin levels, worsens insulin sensitivity and glucose metabolism, and there's a further progression to cardiometabolic disease. The combined effects of insulin resistance, inflammation, lipid dysregulation, and beta cell failure lead to type 2 diabetes progression, cardio-renal metabolic continuum, metabolic complications of the disease. So the cardio-renal metabolic continuum, it is an integrated approach to reduce the cardiovascular and renal risk. The CRM continuum highlights interconnected progression of metabolic disorders, cardiovascular disease, and kidney dysfunction. Obesity, insulin resistance, and diabetes initiate a cascade leading to atherosclerosis, CVD, and CKD. These conditions are bidirectionally linked. the dysfunction of heart, kidney, or metabolic system accelerates damage. So the modern management adopts an integrated multi-systemic approach of glycemic control, blood pressure regulation, lipid management, and weight reduction. It is very important that while treating diabetes patients, you have to make sure that you treat not only diabetes, you control not only diabetes, it is inherently very important to control their blood pressure, to control their lipids, and to try and normalize their weights, because all these together contribute to the ultimate uh, complications that arise in a diabetic patient. So even if your patient has a perfect HbA1c of 6.5 or 7 and develops an MI or a stroke, that is not good for the patient. It is very important to keep all other aspects of diabetes in control as well. In fact, I would like to say that this is the reason why we named our center, our diabetes center in Mayur easily as total care control. So we need total care and total control of diabetes, and total control of diabetes implies control on over blood sugar, control over hypertension, blood pressure, and control on lipids, and control on weight. All these four go together hand in hand. So here we'll have a look, a pictorial look here. So in stage 0, there are no risk factors. In stage 1 of cardio-renal metabolic continuum, there is an excess of adipose tissue or dysfunctional adipose tissue. In stage 2, the metabolic risk factors increase: hypertension, hypertriglyceridemia, metabolic syndrome, type 2 diabetes, and or moderate to high risk CKD. These are already patients who are high risk for CKD. In say stage 3, there is already a subclinical CVD and CKM syndrome, subclinical atherosclerotic cardiovascular disease, subclinical heart failure, which progresses on to stage 4, that is the clinical cardiovascular disease in the CKM syndrome, uh, either heart failure or uh, coronary heart disease, may lead further to stroke, to fibrillation, peripheral artery disease, peripheral arterial disease. So these are risk equivalents of subclinical CVD in CKM stage 3. Very high risk CKD, uh, high predicted risk for CVD using this risk calculator. Inflammation and insulin resistance are closely interrelated to each other. Chronic low-grade inflammation is a key driver of insulin resistance, especially in obesity. Visceral fat releases pro-inflammatory cytokines, TNF-alpha, IL-6, and adipokines that disrupt insulin signaling. This leads to reduced glucose uptake in the tissues and increased hepatic glucose production. So, insulin resistance, hyperglycemia, and beta cell dysfunction. We've already talked about this. And diabetes and hypertension, CVD. Diabetes and hypertension frequently coexist and share same common mechanism. Moment. Hello. Jan Alex, ja ще знову говорить. Да. Insulin resistance, inflammation, and endothelial dysfunction. Persistent hyperglycemia leads to vascular damage, accelerates atherosclerosis, and increases cardiovascular risk. Patients with diabetes have a significantly higher risk of coronary artery disease, stroke, heart failure. Hypertension further worsens outcomes by increasing arterial stiffness and cardiac workload. The common symptoms of diabetes are increased thirst, frequent urination, increased hunger, tingling or numbness in legs, fatigue, unexplained weight loss. But I would I would say here, I'd like to say here that we should not expect these symptoms in all the patients. These symptoms do not occur in all the patients. They are there only when the glucose levels have been high over a prolonged period of time. In So you would not see all these patients. So if there's any doubt about diabetes, family history, so patients should be screened for diabetes, and we should not wait for the occurrence of these symptoms. So there's a whole gamut for treatment of diabetes. There are current therapies which are already available, and there are others which are in pipeline. So they include the medical. First and foremost, we start with lifestyle changes, which include the medical nutrition therapy, physical activity. These are the cornerstones of management of diabetes, and if they fail, then pharmacological therapy, drug therapy, oral therapy is used, and these are the different therapies like gene therapy and artificial intelligence is also being used. Digital therapeutics are being used for treatment management of diabetes. Stem cell therapy is uh, is also coming up with solutions for management of diabetes, especially in type 1 diabetes, even though not widely acceptable and available, but there certainly are certain solutions which perhaps may be available in the near future. There already are antibodies like teplizumab, which are useful in the first stage of type 1 diabetes. So there definitely are newer avenues opening up in the management of diabetes. I'm sure that in the coming decade, after the coming 5 to 7 years, the management of diabetes, both type 2 and type 1, would drastically change, and that too for the better. So my modern diabetes care is no longer just about controlling sugar. It is about improving overall metabolic health and improving long-term outcomes, as we were just discussing. So let us look at what have been the advances in diabetes care. Diabetes management has evolved from glucose-centric approach to a more holistic, patient-centered model focusing on metabolic, cardiovascular, and renal health. There has been a significant progress in pharmacotherapy with the introduction of GLP-1 receptor agonists, SGLT2 inhibitors, and not only GLP-1 receptor agonists, dual agonists, triple agonists, which have GLP-1, GIP, and uh, which are triple agonists, and glucagon agonism. So benefits are beyond glycemic control, including weight reduction and cardiorenal protection. There is also emergence of next generation therapies. Tirzepatide, it is already available. Retatrutide may shortly be available in India, hopefully so. They target multiple metabolic pathways and improved efficacy in both glucose control and obesity management is there. There have been rapid advancements in diabetes technology as well. So continuous glucose monitoring systems are now available and easily available. Uh, they are very accurate and very helpful in monitoring real-time glucose levels. They're good for real-time tracking. Automated insulin delivery systems, hybrid and closed-loop delivery systems, they're improving glycemic stability, and they're achieving almost near normal glucose control in patients with type 1 diabetes. There is a development of digital health solutions, and digital health solutions have shown improvement in glycemic control almost equal to pharmacological therapeutic agents in the terms of HbA1c reduction. So they should not be discounted altogether. There's a development of digital health solutions, connected glucometers, smart insulin pens. So these insulin pens can remember the dose, they can talk to you, and they can be interconnected to a digital ecosystem for better management, better monitoring. Mobile apps enabling remote monitoring and better patient engagement. There's a growing focus on precision management medicine. So there's individualized treatment strategies based on patient profile and disease progression. There's ongoing research in regenerative therapies, stem cell based approaches, and immunotherapy showing potential for disease modification. So there used to be a concept of disease modifying drugs in the management of rheumatoid arthritis or autoimmune disease. Now we have this concept in management of diabetes. We have drugs which not only control the glycemia, but they are also disease modifying, improve the beta cell function. So, as per the diabetes, this is we made this diagram to conceptualize, to give the conceptual picture of the diabetes guidelines, the latest ADA-EASD guidelines. Lifestyle first, so balanced diet and weight control and regular physical activity are perhaps the most important elements in managing diabetes. Then the next focus is on smart medications, that is the GLP-1 receptor agonists, SGLT2 inhibitors, with a focus on heart and kidney protection. And these should be the first line therapy, especially in patients who have a higher risk of these or have already suffered from any event in these. So safety is very important. Hypoglycemia prevention takes upper hand. Patient education and awareness is also very important. Regular care for the patient plays a very important role in the management of diabetes. Regular monitoring, regular glucose and HbA1c checks, lipids and blood pressure tracking, as we were discussing. The total control is also very important in management of diabetes patients. There has to be holistic care, reduce cardiorenal risk, and with an emphasis on patient-centered care. We should always take the point of view of the patient, how the patient looks at his disease, his or her disease, and what are the patient's goals and what patient wants. This is just as important as what we think is important for the patient. The goals of management should be personalized. They can be 6.5 from an otherwise healthy young diabetic person. You should have an intensive control. But on the other hand, an elderly diabetic who's already suffering with significant with comorbidities, the HbA1c goal should be relaxed, and they can be relaxed even to 8.58, especially if the patient is suffering from a terminal illness and has very short life expectancy. So the diabetes goals should be tailored and individualized rather than being hardcore numbers. So the pharmacotherapy, all these agents are available. The alpha glucosidase inhibitors and biguanides, the metformin, bile acid sequestrants, and GLP-1 receptor agonists, TPP4 inhibitors, meglitinides and sulfonylureas, SGLT2 inhibitors, and thiazolidinediones. These are all available agents. So the major trials which have been conducted recently on the past decade, I would say, are these trials. We're going to look at them in detail in the further coming slides. So, what have been the major pharmacotherapeutical advances with focus on cardio-renal benefits? GLP-1 receptor agonists. There has been a shift from glucose lowering to multi-benefit therapeutic approach. GLP-1 receptor agonists, for example, semaglutide, It improves glycemic control, it promotes significant weight loss, and it reduces the risk of CVD incidences, as has been shown in the trials. SGLT2 inhibitors, for example, empagliflozin, dapagliflozin, they lower blood glucose via urinary glucose excretion. They provide strong heart failure and renal protection. They reduce CKD progression, and dual and triple agonists, for example, tirzepatide, retatrutide, they target multiple metabolic pathways: GLP-1 receptor agonists, the GLP-1 pathway, the GIP pathway, and glucagon. They also induce weight reduction and they have metabolic benefits. There's an increased emphasis on renal outcomes. The therapy is now selected based on the ASCVD, heart failure, and CKD risk profiles, which are considered very early in the course of the disease and therapeutics. There's an integrated approach to reduce long term complications and mortality rather than just lowering or controlling glucose. So now we'll have a look at the the major trials which have been done on these drugs that we just talked about. So these Munjaro is the trade name for tirzepatide. This is a dual agonist, GLP-1 receptor agonist, and gastric inhibitory peptide GIP agonist. So it has been studied in its development program on more than 6,200 participants across different stages of type 2 diabetes with active comparators. The Surpass 1 trial has been against placebo for 4.7 years. Add on to other anti-diabetic agents on the Surpass 2, similarly Surpass 3. Also add on to metformin for agenda. This is versus insulin. The Surpass 2 was in comparison with semaglutide, and add on 4 in comparison to insulin. The Surpass 5 was, I think, a Japanese trial versus placebo as an add-on to insulin glargine with or without metformin. This is a long duration trial for 13.3 years. So all these trials have shown significant benefits in weight loss and glycemic control, HbA1c reduction of 2% and more, and weight loss of almost 22% has been shown with Manjaro. Tirzepatide. So this is the Surmount series of trials which were conducted for different doses of weight management, weight loss. As you can see, these are the different doses and these are the different trials. Surmount 1, Surmount 2, only weight management with type 2 diabetes. Surmount 3, weight management with intensive lifestyle modification. And Surmount 4, weight reduction maintenance. And Surmount 5, weight reduction compared to semaglutide maximum tolerated doses. And all these trials have shown effective weight loss reduction. So the key landmark studies, I'm especially not going into the details of the weight loss because that's going to be, if we start taking up all the studies individually, it is going to take a lot of time, and we are already running short of time. So these are the key landmark studies on SGLT2 inhibitors. The empiric outcome was a landmark study on empagliflozin with almost 7,000 participants, 3 years, and the outcome was decrease in CV death by 38%. So that is a big number, decrease in CV death of 38%. And there were multiple other benefits like decrease in hospitalization for heart failure. Similarly, the Canvas program on canagliflozin, almost 10,000 participants, 6 years, and outcome also showed decrease in CV events by 14%. So the empiric outcome had very high risk patients, and uh, the Canvas program did not have that proportion of very high risk CVD patients. But still, we see a benefit in Canvas. The declared TME58 was on dapagliflozin with 17,000 patients, 4 years duration, and heart failure hospitalization reduction by 27%. The Credence study on canagliflozin, this was diabetic kidney disease of 2.6 years duration. It showed decrease in the renal function decline by 30% and showed decrease in ESRD and CV events. So these are the important studies and benefits that we have seen from these key landmark studies. And semaglutide that we've talked about in the the GLP-1 receptor agonist, and semaglutide is now available quite cheap in India. Monthly therapy is available now for as little as 2,000 rupees. A few days back, it used to cost at least 8,000 rupees, 8 to 10,000 rupees. But now the costs have gone down because this molecule is available in generic form, and there are many, many manufacturers. I'm sure in the coming few days or months, the cost of therapy is even going to decrease. So these are the sustained trials which are performed with semaglutide compared to placebo, to oral anti-diabetic drugs, to insulin, to basal insulin, and the cardiovascular uh, safety trial. So these are different trials, and they've all shown significant HbA1c reduction. So these are trials for diabetes, and still you can see weight reduction of 4 to 6 kg in all these 6.5 kilogram in different trials, and HbA1c reduction from anywhere from 1.5 to 1.8%. So we know that these drugs are very effective, as you can see here. Now, this is a newer product. It is still not available, but the data has been released relatively recently. It is orforglipron. It is the advantage of this is that it is once daily oral GLP-1, which has been manufactured or developed by Eli Lilly, the same company which has developed tirzepatide and retatrutide. It is designed for weight loss and blood sugar control. It comes as pill, so no injections are needed, because the other drugs that we talked about, um, the GLP-1 receptor agonists like semaglutide or tirzepatide or retatrutide, they are all injectable drugs. They have to be taken once weekly. Now, it works by slowing gastric emptying, promotes early satiety, and it reduces appetite signal, supports healthy blood glucose levels. And it matters because it is a needle-free alternative to GLP-1 injection. It would improve patient comfort and adherence. So even though studies are there, it has and they are promising with weight loss, even though the weight loss is less than that by tirzepatide or retatrutide, but the advantage is that it is an oral drug and it would have more acceptance. So we have talked about this. Now there have been advances in insulin therapy also, because in the past decade uh, we've had ultra long acting insulin, and now we are going to have insulin degludec, which might be launched in India very soon. It is a once weekly insulin, just as we have once weekly semaglutide, GLP-1 receptor agonist, or once weekly dual or triple agonist. We would soon have a once weekly insulin, a basal insulin, which would be taken only once a week. Now, initially we had better basal insulin like degludec with a much flatter profile, with a much better insulin and glycemic control as compared to the earlier insulins that we had, that is that is levemir and glargine. Uh, and we now also have ultra fast acting prandial insulins, which literally mimic which are very close to the insulin secretion that is seen by the pancreas. Dietary interventions are, we understand that lifestyle modification, including diet, still remains uh, the cornerstone. There have been number of approaches, number of proprietary diets, and the time restricted eating is also picking up. Physical activity is very important. Without appropriate physical activity has number of benefits. So, what's new in treatment of type 1 diabetes? Stem cell therapy is emerging as a curative option. The mesenchymal stem cells, widely explored the mode of action and are multifold, including induces the self-renewal properties, regeneration of beta cell, identification of damaged cells, replacing them with new cells, immunomodulatory and anti-inflammatory properties. So there are global stem cell therapy breakthroughs. Uh, we can see some of them here. Stem cell therapy breakthrough, type 2 diabetes reversed in historic cases. There have been some published case reports, and now uh, there is a commercial stem cell treatment available for type 1 diabetics as well. So this is an outline on the ongoing trials and their outcomes. These are on allogenic umbilical cord derived mesenchymal stem cells, autologous bone marrow derived stem cells, transplantation in type 2 diabetes, and adipose derived mesenchymal stem cell therapy for type 2 diabetes, human umbilical cord mesenchymal stem cells for diabetic nephropathy, umbilical cord mesenchymal stem cells infusion in patients with type 2 diabetic nephropathy. So these are important uh, trials which are already going on and in different phases in phase 1, phase 2, or phase 2A. And the interesting thing is that many of these are on type 2 diabetes patients, and many of them are targeting complications which develop in type 2 diabetes patients. So, in conclusion, diabetes is strongly linked with obesity and metabolic dysfunction. Obesity driven mechanisms, the insulin resistance, chronic inflammation, and beta cell dysfunction. Current management strategies, pharmacotherapy, insulin therapy, lifestyle modification, and glucose monitoring technologies, the regenerative medicines, mesenchymal stem cells, making breakthrough in beta cell regeneration and metabolic restoration. The shift in diabetes care from symptom management to cure, cell therapy with precision medicine and digital monitoring tools improves long-term metabolic control, and regenerative approach expands treatment possibilities. Large-scale clinical trials desirable for determining long-term safety in future diabetes care may focus on restoring pancreatic function and prevent the cardio-renal metabolic complications. Thank you for your attention.
Thank you so much, Dr. Kesri. That was really amazing and enlightening talk on diabetes and modern care. So, we have come to the end of this webinar, and I would like to extend a gratitude of thanks to our eminent speaker, Dr. Rajesh Kesri, the participants for participating in this webinar, and of course, the team in Advancer for making this event a success. Thank you so much. In case anyone have any query, we have dropped our contact in the chat box. You can reach us out anytime, and feel free to contact us. Thank you so much, everyone, for this
Thank you
webinar.
so much. Thank you.
Thank you.